it over to Dr. Manteghi. Thank you.
Well, good evening, everyone. I am Alex Manteghi. I'm the ears, nose, and throat doctor here at Barton. And the title of today's talk is The Nose Knows, Rhinitis and Sinusitis. And I'm going to do my best to demystify and answer all your questions about everything in the nose. And as Natasha was saying, it's especially timely given the thick layer of yellow stuff all over all of our cars. So I am originally from Akron, Ohio. I went to Ohio State for undergrad, graduated from Ohio University for medical school, and then I did my residency in Philadelphia, and I did a pediatric ENT fellowship in San Diego. I worked as a pediatric ENT for 3 years in Philadelphia before coming to Tahoe and starting at Barton in October of 2020. And I live here with my wife and my two children, and we've been loving it ever since. And what else can I say? I'm also a peer reviewer for the Ears, Nose, and Throat Journal and the International Journal of Pediatric Otolaryngology as well. So that's a little bit about me. And objectives of this talk, we're going to discuss sinusitis and rhinitis, what they are, how they occur, why they occur, what's the sinusitis, what's rhinitis. We're going to describe the anatomy of the nose, and we're going to review medical therapy as well as procedures where medical therapy falls short. I kind of like this cartoon, which kind of applies right now. It's nice to stop and smell the roses, but with your allergies, keep going and Google them. And especially with everything that's floating around Tahoe right now, this cartoon picture does apply. So the function and purpose of the nose. The most obvious is breathing. It serves the nose serves as the primary entrance point for air entering and exiting the lungs. The structures inside the nose also warm and moisten the air that comes in. It humidifies the air. And given that Tahoe is so dry, that's even more important. It filters all that stuff that comes in, the dust, the pollen right now, the particles from the air, and it helps prevent them from getting in the lungs, especially as it gets stuck in the mucus that is naturally produced in the nose. The sense of smell, the smell fibers come up high up in the nose, and it also helps protect. So the nasal mucosa and the cilia trap all that stuff coming in the nose as best as it can and prevents them from reaching the lungs, sorry. So how about the sinuses? Now, and I should maybe back up, for a second, say the nose and the sinuses. When I talk to patients about the nasal passages and the sinuses, I say the nasal passages are like the hallways of the nose, and the septum is this wall that divides right and left, the right side from the left side, and we'll get into that more. You can think of the sinuses like rooms off of the main hallway, these air-filled structures. They help to lighten the skull. They reduce the weight of the skull, contributing to an overall sense of balance. And they actually help to produce the resonance and the quality of our voice. And because they are these open spaces when our voice comes up from our lungs and from, past the vocal folds, there is somewhat of a resonance in our sinuses. That's also why you sound congested when your sinuses are blocked up and less so when your sinuses are open. They produce mucus, and that mucus drains into the nasal cavity, again, helping to trap and remove pathogens. It also humidifies air, so a lot of the same things that the nasal passages do. And it can help absorb the impact of head injuries as well. So when we talk about the nasal anatomy, it's a complex, there's a lot of things going on in the nose. Kind of what I was saying before, the septum is this wall made of bone and cartilage that divides the right nostril from the left nostril. And by itself, it doesn't have a significant inflammatory component, a small one, but not nearly to the degree of the turbinates. So the septum are shown in these two pictures, and then the turbinates are there's three of them, and the lower ones are the most significant in terms of their function. But there's a lower, in this picture here, you can see a middle one there, and these are the things that humidify, filter air, and produce mucus. When they're big, with allergies, colds, illnesses, you'll feel that as inability to breathe well through the nose. When they're small or decongested, you'll have more space. And here I have a picture showing because really, and I should back up, but really what we breathe through is that space between the septum and the inferior turbinate. In this top picture, you can see there's a nice space around it, whereas this lower picture, you see there's not much room around it, and you can't see the back of the turbinate. It's all congested. So the three turbinates, I said that the lower one is the most significant in terms of airflow. The middle turbinate we'll talk more about later in discussion. Now our tear ducts drain into our nasal passage as well, right adjacent to on the other side of this turbinate. And then in the back of the nose, we have the eustachian tubes. The eustachian tubes connect the back of the nose to the ear, and those are what are responsible for popping our ears with elevation changes. So anatomy of the sinuses. We talked a little bit like these are like rooms off the main hallway. In this picture here, you can kind of see the septum in the middle and these turbinates on the side. But the sinuses, there's 4 sets, and I kind of like to relate them all to their position relative to the eye. The maxillary or the cheek sinuses are just below the eye. The frontal sinuses or the forehead sinuses are above the eye. The ethmoid sinuses are adjacent to the eye and in between the eyes. And then the sphenoid sinuses are these ones all the way in the back. The ethmoids kind of are close to the eyeball, as you can see here, and close to the skull base. The CAT scans, we often get CAT scans with patients with different types of sinus disease. And when you look at these scans, black is air, white is bone, and gray is soft tissue. With the sinuses, we want to see a lot of black. And if we look at this top one, these cheek sinuses, you see black. These are well-aerated sinuses, and there's no disease in here. And I should also point out one thing. Remember this for later in the discussion, but the openings into the sinuses, they're not big. They are 3 to 4, 5 millimeters, and it doesn't take much to congest them. That's this little black line here. Visually, what we breathe through again is the space in between the septum and the midline and the turbinates on the side. With sinus disease as shown in this picture, you can see this thick layer of gray stuff in either of these sinuses. That can be related to mucosal inflammation, polyps, or just diseased mucosa. And we'll discuss that more later on. Here's a image of a forehead sinus blocked on this left side. Left and right are they're opposite when you look at a CAT scan, but this is actually the patient's left side, whereas this right side is nice and open. So nasal congestion has a lot of causes. Rhinitis is a general term for inflamed nasal lining. There's a lot of things that cause rhinitis, but when your nasal lining is inflamed, you have congestion, runny nose, sneezing, itchy eyes, and we kind of divide the types of rhinitis into allergic, which is more immune related, and non-allergic, which is think of different irritants that can make your nose runs that are not allergy related. Allergic rhinitis is very common. It affects up to 40% of children, especially in those with a family history of asthma or allergies. Whereas about 10 to 30% of patients will have allergic rhinitis symptoms at some point in their life. Non-allergic rhinitis symptoms account for about 25 to 50% of all cases of chronic rhinitis in adults. Strictly speaking, they're less common. It's less common in children, except for the big viral infection cause, which we'll talk through. So allergies, allergic rhinitis, they're caused by allergens in the air. And your symptoms, your body's responses result from an overreaction of your own immune system to whatever it's being exposed to. So your body produces specialized antibodies called immunoglobulin E, and those immunoglobulins travel to different cells that overreact and produce the symptoms we experience as sneezing, stuffiness, runny nose, itchy, hay fever symptoms. There's seasonal allergies, which are more seasonal based. So trees are more prevalent in the spring, grasses are worse in the summer, weeds are more prevalent in the fall. And then there's perennial allergies or year-round allergies, exposure to animal dander, certain molds, dust mites, cockroaches. Cockroaches, believe it or not, have a strong association with allergies and asthma. There are different websites like weather.com where you can check the pollen counts on any particular day. Non-allergic rhinitis, there's a number of causes. Probably the 2 most common reasons that I see: the common cold. If a virus gets in your nose, all of those mucosal surfaces in the nose become inflamed and start overproducing mucus. They get swollen up, they get congested, and they lead to the typical symptoms that we experience with colds. And usually there's a progression of symptoms with the common cold, starting with congestion, runny nose, progressing to sneezing. Mucus starts becoming thicker and more discolored, and maybe a slight fever, usually lasting a week or 2. Children are most affected, especially under 6, because they have immature immune systems. And it's not uncommon for a kid to have 8 to 12 infections in a year. And if they're each lasting a week or 2, you can do the math and see in some cases that can be up to half a year, especially in kids that have an underlying history of allergies or are in daycare or preschool symptoms. And every year is going to be a little bit different. Rhinovirus accounts for 30 to 80% of all colds. So that's probably one of the biggest causes. But another one that I see in my office quite frequently is just as we get older, our nose runs. We start to lose regulation in our nose, and as we get older, you may find yourself carrying tissues with you everywhere you go, and it can be a year-round problem. Um, I lost my slide here. So over 60% of rhinitis patients over 50 have a non-allergic etiology, and that's just a year-round thing. And it can be worse with irritants such as temperature changes, cold weather, spicy food, exercise, elevation changes, even pregnancy. These are all the different things that can cause non-allergic rhinitis. But simply as we get older, our nose runs more and more and more. And it's not allergy, and it is not tied into seasons or anything. It's just a year-round problem. We'll discuss treatment for that in a second. So one that we kind of discussed here, drug-induced. Unfortunately, I see this a lot as well. This is when patients have congestion, they'll turn to they'll turn to what they can find at a pharmacy. Afrin, Sinex, four-way nasal spray, over-the-counter sprays. These are all common nasal decongestants that contain oxymetazoline, and maybe not four-way. That's phenylephrine. We'll talk about that in a second. But Afrin, Sinex, and these like CVS or Walgreens brand oxymetazoline. These are not meant to be used for prolonged use. They work exceptionally well for a short period of time, but the bottle says don't use it for more than 3 days. But they work well. They set in fast, and you can breathe, and you're happy. The problem is not everyone reads the bottle, and they keep using it more and more and more. Well, the problem is these decongestants, they are shrinking those turbinates we discussed before. When those are smaller, there's more space, you can breathe better, you get relief. But the longer you use it for, those turbinates develop a rebound congestion where they start getting bigger. They get bigger, and you want to use the spray more and more and more. So you're trying to use it more, but over time the effectiveness goes down, and that's how your nose can get quote unquote addicted. Then you have a patient coming in that's using this 4 or 5 times a day, but their turbinates are swollen, huge, and the nose is just completely shut off. So this is one thing you can take away from this. These are great sprays to use here and there, meaning in the middle of a cold for a few days. Some people use it before a big hike to give themselves more airflow, but they are not meant for use more than 3 days in a row. So we're going to discuss medical management for rhinitis, allergies, and non-allergic rhinitis. We're going to discuss nasal steroids, antihistamines, nasal decongestants, and saline rinses and other treatments. There's a lot to choose from. They are all over the counter, so we're going to try and give you some relief. Saltwater rinses, Flonase, Nasacort, Astepro, Zyrtec, the Navage, which is a newer and effective saline delivery treatment system. So we'll try to give you some clarity where to start because there's a lot over the counter when you go into any pharmacy. Nasal steroids are probably one of the gold standards for treating moderate to severe allergies. And they work by spraying that you spray in the nose. And when you spray any of these nasal sprays, you spray off to the side because those turbinates that we mentioned, they're off to the side. So when you put in any of these in your nose, you're pointing up and out. And that's true for pretty much every nasal spray. They reduce inflammation of the nasal mucosa they contact, and it's highly effective for allergies in majority of patients if there's an underlying allergy component. It's less effective for non-allergic rhinitis, but still somewhat effective. Now, the thing is we have to understand about any of these Flonase, Nasonex, Rhinocort, Nasacort, Nasonex, they're effective, and especially Flonase and Nasonex, they will work within 12 hours, but they reach their peak effect within 1 to 4 weeks. So they are meant for more prolonged use. There are other medications we'll discuss with more immediate onset if you're having temporary and you need something quick. But while they do work and they build up to their effects, they take some time to build up to that effect. They can be used to prevent symptoms when used prophylactically. If you know the pollen count's going to be high, we're going to spring, and it's good to get started ahead of time to get the benefits of the medication. And they're indicated for patients with nasal polyps, which we'll discuss in a little bit. So these all actually have fairly similar efficacy for allergies, with symptom reduction scores of 50 to 60% across the board, according to one meta-analysis. Fluticasone and mometasone are a little bit more potent and have a quicker onset, just a slightly quicker onset, but it's not a big difference. I have some patients that love Flonase, some patients that hate Flonase. I have some patients that say Flonase didn't work at all, but Nasacort or Rhinocort worked beautifully. So everyone's a little bit different, and we just try and find what works for the patient. So antihistamines, oral antihistamines and nasal antihistamines. Antihistamines are very good for reducing hay fever symptoms related to allergies. So someone's cutting the grass, or you're walking outside right now at this time and your eyes are watering, you're sneezing, you're itching, you're having runny nose. These work great. There's first generation, which we really don't use too much anymore, like Benadryl and chloramphenicol, but more commonly now we're using these second generation antihistamines, Zyrtec, Xyzal, Allegra, Claritin. These have a faster onset and they work within 1 to 2 hours and provide relief for a longer period of time, 12 to 24 hours, versus older ones that, these only will last for 4 to 6 hours. While they're good for reducing those hay fever type symptoms, they're not as good for actual allergic for nasal congestion, which is obviously a hallmark of allergies. And they don't have as much of an impact on non-allergic rhinitis or chronic sinusitis. Okay. So these are better for temporary mild to moderate allergy symptoms. And nasal antihistamines are also work well as well. They also work very well, especially Astepro. These are over the counter. Well, this one is in particular, Astepro is over the counter, and this has an even faster onset, 15 to 20 minutes. When you're exposed to allergy, when you're exposed to, like, someone cutting the grass. So there's oral and nasal, but nasal as a whole acts faster than oral. Cetirizine or Zyrtec and levocetirizine, these are a little more effective on a whole than Allegra and Claritin, but they have a higher rate of sedation, 5 to 10% in patients, whereas Allegra is the least sedating. So when we compare antihistamines and nasal steroids, people often ask which one is better. In most studies, including this 2015 meta-analysis, nasal steroids were more effective at reducing total nasal symptom scores, but that was with prolonged use. So if you had checked that on day one, antihistamines would probably be a little more effective but these studies were for 30 days plus. So nasal steroids were found to be more effective at reducing total nasal symptom scores. Antihistamines were less effective, but they were for congestion, but they were comparable for sneezing and itching. So overall, oral antihistamines are faster acting, making them better for acute symptoms, but nasal steroids are preferred for sustained control, especially if you're going to have allergic symptoms for a prolonged period. So when we compare nasal steroids and intranasal antihistamines, this is comparing like the Flonase to the Astepro. Flonase was better again for nasal congestion, but azelastine had a faster onset, 15 minutes versus hours. But the interesting thing was combining the two into it was more effective than either one alone, reducing symptom scores by up to 40% more than either one alone. There is one nasal spray called Dymista, which combines the two, and I like it a lot, but unfortunately it carries a higher price tag. So how about non-allergic rhinitis in those patients, especially older patients, where your nose runs continuously year-round, regardless of the season? Ipratropium bromide is excellent for those patients in particular. It helps patients where your primary symptom is a clear runny nose that you're always carrying a tissue wherever you go. You can use this 1 to 4 times a day. It has minimal side effect. When you use it, the spray lasts for about 6 hours. And some people need it once a day. Some people have to use it 3, 4 times a day. The main risk I tell them is if you overdo it, you can run the risk of dry nose. Now, interestingly, if patients respond well to this and they don't want to take this forever, there is a treatment called in OR. Right now we're doing this procedure in the OR where it uses a cryotherapy balloon, and we actually apply this balloon to specific spots in the nose, freeze those spots, and we're trying to target these posterior nasal nerves. Basically we're hitting the reset button on these nerves, and we're targeting these overactive nerves that cause you to have your nose run over and over. It's minimally invasive. It takes about 20 minutes and can provide long-lasting relief for up to a year or more. Not everyone needs that. Some people are just happy with the ipratropium, but for patients that want a longer-lasting treatment, that cryotherapy treatment works well for them. We talked a little bit about the decongestants, Afrin, Sudafed. So there's oral. Sudafed is the most effective oral decongestant. Phenylephrine, as of November of 2024, the FDA, we're close to having all phenylephrine removed from the shelves because they are just not effective. There was a big study, and this has been around for years, but phenylephrine is not effective. No more effective than a sugar pill. So be careful. Look at your decongestants that you have at home because phenylephrine just doesn't according to multiple studies now, does not do a whole lot. They're still on the counters, but they should be off the counters by 2026. Sudafed is you can think of this as an oral form of Afrin, but Sudafed does not carry the risk for rebound congestion or tolerance, but still you should not use it for more than 7 days in a row. It's an excellent decongestion, but you have more side effects, including raising your blood pressure. But in the middle of cold, if you're in the middle of a bad sinus infection, I'm okay with using these for Afrin for no more than 3 days, or Sudafed during a bad cold. That'll provide some symptom relief to reduce the congestion in your nose, but also open the sinuses. Now, we expectorants and cough suppressants. Expectorants, Mucinex, or guaifenesin. What this is trying to do is thin the mucus. You have to drink it with at least a cup of water, 8 ounces, for it to be effective. And the more water you drink, the more effective it's going to be. For patients where their primary symptom is thick phlegm, this will help thin the mucus. It won't stop the mucus, but it'll make it easier for it to come out. And cough suppressants like dextromethorphan, or typically under the name of Delsym, that helps to cough, control your cough when you're sick. Now, it's also important to look at the trade name. Mucinex and Delsym are trade names, but it's really important that you look at what the generic name is. So guaifenesin was what the medication that thins your mucus. Dextromethorphan, or DM, is what stops the cough. You combine the two, and you get Mucinex DM, where it combines those two medications. So make sure you look at the box, not just the trade name, but you're actually looking at the actual generic name, because sometimes you may think you're getting one medication, but if you have 4 or 5 different boxes, you may be overdosing. If there's different medications, or if there's overlap in those medications. So which one should you take? You kind of tailor it to the symptoms. If you have clear runny nose and you have allergy symptoms, sneezing, itchy eyes, if you want immediate onset, go for an antihistamine, either nasal or oral. But if it's a long season, go for the nasal steroid like Flonase or Nasonex or Nasacort. If you're having thick postnasal drip, discolored drainage, using an expectorant to help thin that mucus out can help, like Mucinex. Also, using saline rinses with saline rinses, I tell patients that's a hose for the nose. You're just trying to irrigate as much as possible the stuff that's in your nose, and you're trying to rinse all that stuff out of there. If you have a bad cough, a cough suppressant like dextromethorphan, anything with DM will help. And if you have a cough and you have a thick phlegm, then using a combination like Mucinex DM will help. Now, for allergies, if medications can only do so much, the antihistamines, the nasal steroids, for patients with really bad allergies where you get to a point where it's not working, seeing an allergist, getting allergy testing can help. So once you have the results of skin allergy testing, you can tailor therapy by starting allergy shots. Allergy shots basically get injected with what you are allergic to, and it's for patients with severe allergies. You are exposed to, first on a weekly basis and then eventually a monthly basis, you're exposed to very small amounts of the allergens you're allergic to. And by little, it helps you build tolerance so you become less reactive to those allergens. It helps reduce symptoms and the need for medications, and you give them, again, over first weeks, then months, but in most patients, it's a 3 to 5 year process. And full effect may take at least 6 to 12 months to reach that a full effect. It can be given as shots, and that's usually given in a doctor's office, weekly at first, then monthly. In less severe allergies, you can give sublingual drops, where a doctor formulates what you're allergic to and just takes some drops under the tongue once a day, and you can do that at home. We're still working on getting this in Tahoe, because right now we don't have a full-time allergist or a nursing team that can give these shots. That's the only unfortunate thing right now in Tahoe. So what do we do if medications aren't working, and what else could be contributing? I know that's a lovely picture. That's more for winter, but nasal endoscopy. This is what we use in the office. And in the office, we put cameras in the nose so we can see what's going on. It gives us a more in-depth 3-dimensional view. I'm going to play a video here in a second, but let's start off with this picture down here. This is your septum, and we're looking into the right nasal passage. The turbinates, the things that get congested, this is a pretty small turbinate. We can say that because we can see all this room in between, and we can see all the way to the back of the nose, even though there's a shadow there. And then up here, you can see the middle turbinate. And here, we can see a disease turbinate. This is a patient that's had sinus surgery because, well, it appears they had sinus surgery because this is a wider opening. And when we look with the camera, we can see that's how we diagnose as ENTs. We want to, when we say diagnose a sinus infection, we actually like to look in the nose and see this stuff draining out to help confirm that diagnosis. And we can actually, one advantage of, coming to an ENT is we can use our cameras and under direct visualization, pass swabs into the nose, directly into the sinus to take directed cultures. So we can see what's growing on those cultures so we can tailor antibiotics specifically for the bugs that are growing. Here's a video. Let's see if it plays. Hopefully it does. Okay, so this is going into the nose. This patient has a deviated septum. You can see this sharp spur over here, and it's kind of driving into the sidewall. But you see the middle turbinate up here, this lower turbinate down here. Again, the turbinates, and one thing I had to mention, the turbinates actually do fluctuate in size. Every 4 to 6 hours, one side of your nose is more congested than the other, and back and forth it goes. Now the sinuses drain. Well, this is the back of the nose, and that's right here. That's the eustachian tube. This is the tube that goes up to your nose. When you swallow, when you yawn, that's the thing that helps pop your ears. The sinuses drain from this crevice to the side of right in this crevice. This is where the sinuses drain. This is where we want to see, or if you have an infection, where we'll see drainage coming out. It's also what we surgically address at the time of surgery to open. We can open up these openings to make them bigger so your nose can quote unquote breathe better. We'll talk about that more in a second. So let's talk about a deviated nasal septum, probably one of the more common problems we see patients for. Deviated septum can be due to a number of causes. You can be born with it. It can be from commonly after trauma. It means this wall that divides your right nostril from your left nostril is pushed off to one side or another. It doesn't mean that the entire wall is pushed into the whole nasal cavity. Sometimes it can be like the video we just saw where you have this spur going to one side. In this picture here, this is looking again into the right nasal passage. The turbinate is here, and this septum should be straight, like it is here in this middle picture. Instead, it's diving into that wall, so there's less room to breathe through. Now, sometimes you can see it from the outside, and this is not as common, but in rare cases, you can see it from the outside, like in this patient. These are examples of what a deviated septum looks like from a CAT scan. And this one particularly, this is a very severe one where you have this shelf of bone going off into the right nasal passage. Here, this is what it looks like from a different angle when you're looking. This is looking at a patient straight on, whereas imagine the camera is pointing straight down from the ceiling at them. And here's another example of a septal spur. So this is what a CAT scan might look like. And this is what we see when we put a camera in the nose. One thing I forgot to mention, when we do put a camera in the nose, I'm going to go back for a second. When we do put a camera in the nose, how we do it in the office, we spray your nose with the decongestant and numbing spray to make it a more comfortable procedure. It's not the funnest procedure. Most people describe it as a weird sensation. But the spray decongests your nose and it gives us more space to operate our scopes, but also provides some a numbing aspect so you don't feel it as much. Plus, in our office, you can see everything we see on the TV screen. So we can be looking at the same thing and talk through the same pathology. All right. So how do you treat this? Well, a septoplasty is a procedure where you make an incision all inside the nose. You make if we need to treat it. Maybe I should back up for a second. 70 to 90% of the patients in the whole world have a deviated septum. It's a very common finding. The only patients we ever need to operate on is if medications aren't helping and you notice it. It's affecting your quality of life and you want to breathe better through your nose. You tried Flonase, you tried Nasonex, maybe you tried some antihistamines and nasal sprays, and it's not effective. We look in your nose, we see the deviated septum, we look with the camera, we will get a CAT scan to get a further visualization. And if it's not helping, yeah, septoplasty can help. You make an incision inside the nose, you raise up this tight lining of mucosa off of the bone and cartilage. And once it's totally raised off, you can see, then you can address the bone and cartilage that's pushing off to the side. You can use a series of instruments, use scissors, use chisels, different instruments. Sometimes you have to remove, like in this case down here, you would have to remove this mangled piece. And sometimes we take something in, take something out, put it back in, all with the goal of getting something like this, a straight septum, and removing the deviation. We often also will shrink these turbinates in many cases at the same time, because if these are smaller, really what we're trying to do is maximize this space in between the two. We're going to talk about turbinates in a second, but And so that's about usually an hour and a half procedure for most patients, 2 hours for some. After we're all done with surgery, we close everything up. You have these plastic splints inside your nose that help to sandwich the septum together, and they help to the healing process. 5 to 7 days later, you come into the office, we remove them, we clean out any crusting from the nose. Patients can breathe well through their nose. There's usually some crusting that develops over the next few weeks. But we have patients come in again a few weeks later to clean out that crusting. But the goal is to improve airflow, and in a lot of cases, this has also been shown to decrease snoring as well. It doesn't stop sleep apnea, but there has been statistically significant improvement in snoring with these patients. All right, so the turbinates we just discussed, oftentimes if we do address them surgically, it's at the same time as a septoplasty in many cases, not every case. The turbinates again are they get bigger and smaller with irritants, whether it's allergies, non-allergic causes like colds, bad illnesses, viruses. These swell up, and remember, every 4 to 6 hours, one side's more congested than the other. That's called the nasal cycle, and back and forth they go. Uh, if medications aren't helping, we can shrink these turbinates. We can make them smaller. We'll discuss that in the next slide. But here's a picture of like before surgery where this turbinate is just taking up more space. After surgery, our goal is not to remove the turbinate. No, you just want to reduce it. You want to make it smaller, but not, and you don't want to overdo it either. That can lead to complications. Our goal is just to make it smaller, provide more space, not remove anything or overdo it, but we want to be able to see a nice space around it and in between the septum. We want to be able to see ideally, I want to just by looking in the front of the nose, I want to be able to see all the way to the back of the nose. Now, this on a CAT scan, these are what these scrolls of tissue look like. And again, look at that little space, that black line. That's the space we breathe through. Surgery just tries to maximize that if medications are not doing the job. So there's different methods to reduce turbinates or make them smaller, but a lot of times it's just by making a little incision in the turbinate from the front. And you can use different instruments. You can use like little shavers. You can use radio frequency probes to shrink all of this mucosa by making multiple passes. And you can also remove some of this bone because actually, let me go back to this picture here. The turbinate, this is a layer of erectile tissue. It gets bigger and smaller. It gets, like allergies make it worse. Afrin or other decongestants, as Sudafed will shrink them up. It does have a small piece of bone in it, but it's mostly erectile tissue. So you can remove the pieces of bone in the middle. You can pass probes to shrink it. There's a few different methods, but all with the goal of making it smaller. So when you're done, you're happy. Now, the middle turbinate. The middle turbinate, its main. It does all the same things that the inferior turbinate does, but it's not quite as responsive to medications. But it does act like as a gate to the sinus entrance. In this crevice, in this crevice, that's where the sinuses drain. If these are too big, and sometimes if they're too big, they take up space, your sinuses can't drain properly. Here's a patient, and this is kind of hard to see, but one common pathology is something called a concha bullosa, where you have an air cell in the turbinate that should not be there. If you look at this left side compared to this right side, which is a smaller normal one, this left side is just taking up space. We have surgeries we can do to reduce this. A lot of times we'll just, remove half of the turbinate in this case, so that you're more or less deflating the balloon. Here's a pre-op and post-op picture. So these are important for sinus drainage. If they're too big, they block your sinuses and they have to be addressed. Most patients don't need to be addressed. Only 10% of the population has some form of pathology here that has to be addressed. That's not including polyps, which we'll discuss. Now, the nasal valve, this is the part of your nose it's the narrowest part of your nose. And this part on the outside here, it can collapse inward when you're breathing in. Okay. So if you have trouble breathing through your nose, especially during inhalation with exercise, anything where you're breathing through your nose fast and your symptoms of nasal obstruction worsen, you may have nasal valve collapse. You can do this by placing 2 fingers on your cheek and gently pulling the skin sideways, around your nostrils. So there's a picture there, and there's another picture of where the collapse usually happens. But that's something you can do at home as a test for that. When we are in the office, we can put a camera in there and literally see if there's any collapse or not. Not everyone has this, and it all comes down to the strength of the cartilage. One of the main factors is the strength of the cartilage on the outer nostril rim. Sometimes this valve collapse can happen after trauma, or if you just have underlying weak nasal cartilage. So yeah, we can see it in the office, but a good test doing this If your symptoms get much better with that, you may have nasal valve collapse. There's different treatments, and Breathe Right nasal strips. They act to there's these plastic, not plastic. There's like these Band-Aid looking things you put over your nose to help to pull those nasal walls open, namely when you're sleeping at night. If those do help you, you likely do have nasal valve collapse. Some people will turn to nasal dilators where you have these cone-like devices, which is it's basically just putting something in the nose that looks like a cone that helps to keep that nose dilated and helps it from collapsing. That's another over-the-counter treatment. Nasal steroid sprays don't actually do anything for nasal valve collapse, but if the turbinates are smaller in the nose, you may notice it less. In office treatments or even in the OR, Latera is something where you can actually you can place a bioresorbable implant under local anesthesia under the area that collapses, and it acts to support the collapse. So it's basically like a support beam. That's the easiest way to put it. That's effective. There's something called VivAir where you can actually use radio frequency, apply it to the area of collapse to remodel and reshape that tissue, and it stiffens that side wall so they don't collapse as much. Oftentimes, these can be done at the same time as a septoplasty or turbinate reduction if those are needed as well. Now, if in other cases, we can look at and say it's too severe for these in-office treatments, and a rhinoplasty where we actually have to open up the nose to take cartilage from one part of the nose and place it as a support beam in that area. That's a possibility in more severe cases. All right, so let's talk about chronic sinusitis, and we'll get into that. And here's some pictures. We talked about, I remember on these CAT scans, black is air, gray is soft tissue, and white is bone. So this on this left side in this patient, this is a well pneumatized open sinus, and then you have this black, grayed out cheek sinus with extension into the ethmoids along the eyeball. Whenever I see one-sided maxillary sinus disease, one of my first thoughts is always dental disease. If you can see in this picture, the teeth roots are sharing the same interface as the sinuses. That's why if you have bad dental pain, you'll feel it in your sinuses, and vice versa. If you have a bad sinus infection, you'll feel it in your teeth. But dental infections can be a source for sinus infections because it's right there. It seeds the sinus and it spreads. So not everyone that has sinus disease has dental disease, but if it's one-sided, especially on a CAT scan, then that's one of my first things I'll look at. Now, the sinus openings, we don't see it really well here, but the natural sinus opening for anybody, it's 3 to 4 millimeters, 5 millimeters at max for most patients. That if you think of it that way, you think of these nasal passages like hallways, but the sinuses are rooms off the hallway. Those doors into those sinuses are small. So if you get inflamed, whether it's a bad cold, bad allergies, it doesn't take much to shut off those, to completely slam the door shut on those sinuses. And once it's shut, especially that's how a cold can turn into what we consider a sinusitis. A cold is viral inflammation of all the lining in the nose. A cold it'll cause inflammation of the nasal passages of the sinuses. And it's just tissue inflammation at that point. But if those doors, quote unquote, stay closed enough for long enough, then this room gets shut. If this room is shut, then that's where you get these bacterial things that can start percolating. That's how a viral infection, which may last a week, can turn into a sinus infection if symptoms worsen after, say, 10 to 14 days. So that's an important point because if you have underlying allergies, if you are just someone that's always swollen and congested, you're much more prone to a sinus infection because those openings are already small and it doesn't take much to completely shut them. This is a picture looking into the sinus of what a sinus infection looks like, what we would see if we put a camera in the nose. So what are the different kinds? We will acute sinusitis versus subacute versus chronic. Acute is anything less than 4 weeks. Chronic lasts about over 12 weeks. And then you have this middle gray area, which is subacute. So initially, most cases of rhinosinusitis are either viral or bacterial. Most things when they start are viral, but they can transition to bacterial through the reasoning we just discussed. And symptoms usually include sudden onset of facial pain, congestion, discharge. We're going to talk more about the major and minor criteria for diagnosing sinusitis in the next slide. But if it's been more than 12 weeks, then it's not just infectious, but more of an inflammatory component. The longer you have stuff trapped in your nose, the more the tissue, that mucosal lining of everything, of the nasal passages of the sinuses becomes inflamed. And the more inflamed they are, the more mucus it produces. And it's a hard cycle to break out of. So the major symptoms of chronic rhinosinusitis, again, 12 or more weeks of symptoms are nasal obstruction, nasal discharge, facial pain, reduced or absent smell. The two biggest ones we look at are nasal obstruction and nasal discharge or postnasal drip. Diagnosis requires at least two major symptoms, one of which must be either a nasal obstruction or the nasal discharge, and we see objective evidence, either by putting a camera in the nose and seeing the pus draining out, or a CAT scan where we see the sinus inflammation. So what do? We maximize medical therapy. If we see green stuff draining out, we will often treat with varying courses, varying duration courses of antibiotics. Usually we start with a smaller course of 7 to 10 days, but sometimes patients have really bad symptoms. They come back, they're not fully going away. That's when we have to use longer courses, even up to 21, 28 days in some cases. Nasal steroids, what we discussed before, Flonase, Nasonex, they help to reduce inflammation in the nose. And again, we're trying to reduce the mucosal swelling so the sinuses can quote unquote breathe better. Sinus irrigations are excellent it's a hose for the nose. You're trying to rinse that mucus out as much as possible, get all that stuff that's trapped in it, get all that stuff that's trapped in there out of there. And mucolytics that we discussed, they thin out mucus. They don't stop mucus, but they thin it out so it gets out easier, especially when you're using it in combination with saline rinses. If patients have bad allergies, antihistamines are sometimes indicated if there is a significant allergic component. So nasal polyps. Nasal polyps are an advanced end stage of inflammation. It's tissue that's inflammatory in nature. The more inflammation, the more polyps you're going to see. The less inflammation, i.e., if we treat with oral steroids, they'll shrink up too. They can come or go depending on what degree of inflammation there is. These are some pictures of what they look like. When they are big, they block your sense of smell. You can't breathe through your nose. Your nose runs. So we're going to talk more about that in a second here. Again, inflammatory growths, and it's from prolonged inflammation. That can be allergic reasons. And then in some patients, they can be there from non-allergic causes as well. Postnasal drip, facial pain, pressure, they're blocking those small 3 to 4 millimeter sinus entrances. And so when those cheek sinuses are blocked, that's where you get all those symptoms we just discussed: the facial pain, the pressure, the obstruction, the pain radiating to the forehead, the pain radiating to the teeth because the sinus is all inflamed. We often see polyps in patients with sinus infections that have gone on for long periods of time that have not been treated well. Asthma, aspirin sensitivity. There's something called Samstra's triad where we see patients that have not just aspirin, but a sensitivity to Motrin, Aleve, ibuprofen. There are a select set of patients that are overreact to those medications where you can see nasal polyps, and something called allergic fungal sinusitis, which I'll discuss more in a second. Again, so the nasal spray, the treatment is there's medical management, which we'll discuss, and then there's surgical management. Initially, we're trying to rinse out all the mucus from the nose with saline. Sometimes the polyps are so obstructive, you can't even get the saline rinse bottles in there. We can use neti pot rinses. We can use the Navage machine. That's a machine that actually does all the work for you. And think of it like saline with low volume and high volume. The low volume are the small little bottles. The high volume are the big squeegee bottles like the Neilman rinses. That's where you're trying to really put as much, you're trying to put some effort in there to get that stuff out of there. Nasal steroids are helpful, like Flonase and Nasonex. But I find in most of the time with patients with bad polyps, we go right to budesonide rinses. Budesonide is also a nasal steroid, but they come in vials, and this is off-label use. But budesonide vials are often patients use it in a nebulized form in treating asthma or COPD. You can actually take that vial, empty it into a nasal saline rinse bottle, mix it up, and apply that in your nose so that it gets into the sinuses even better. Because you can imagine those little small bottles, they don't get in very well to all the nooks and crannies where it needs to get into. You can also mix in an antibiotic ointment, Bactroban, if there's a significant infection where you see green yellow stuff getting in. So that way it's really getting into the spaces it needs to get into. Oral steroids are very effective for nasal polyps, but we caution that we only use those if someone comes in with severe symptoms. We don't just give patients steroids if we see polyps. It will only give it for patients, let's say they get a bad cold, bad inflammation, and they're just miserable. Polyps are taking up they're completely obstructing the nose. They're blocking the sinus entrances. Maybe they have fevers. So they're on an as-needed basis, not a long-term solution because they have a number of side effects. We even have a steroid side effect sheet that we have patients review before starting steroids because there are a number of side effects. But think of it as a rescue medication. Antibiotics, not necessarily for the polyps per se, but if we see bacterial infection at the same time, they can be used as well. Now, probably one of a newer treatment for polyps. It gained approval in 2019. Dupixent is the only FDA-approved monoclonal antibody for chronic sinusitis with nasal polyps. This is a medication that's also given for patients with, for also approved for patients with severe asthma and atopic dermatitis because you have a similar inflammatory pathway that leads to all three pathologies. But it blocks two of the key drivers of the inflammatory process that leads to polyps. And so it's fairly it's effective. It's just hard to get approved. It's given as a you self-inject it every 2 weeks. It's not a first-line therapy. You first try all the medications we discussed first, but if those aren't helping, it's an option. And some patients use it in some cases where they want to avoid surgery, and it is an option for patients more in mild to moderate polyp cases, not severe cases, where this medication can shrink those polyps and reduce all the symptoms. So it reduces the polyp size, it improves your sense of smell that the polyps get smaller, it decreases needs for oral steroids and surgery, and it's fairly well tolerated. So again, this is a newer thing from 2019, but this is a newer option we have where it's not just medications or it's not just surgery. It's just harder to get approved. And that's the biggest hurdle. This is sinusitis. Most cases are limited, it's symptom limited to what we discussed. But the sinuses are next to the brain, they're next to the brain, next to the eyeball. There are rare cases, especially in kids, where a bad sinus infection can get into the eye, it can get into the brain. Most adults, this doesn't happen, but if you're having symptoms that go uncontrolled for long enough, there are cases where you get eyeball swelling, brain infections like meningitis. And it's really this is just a slide just to make sure don't let anything go for too long because it's right next to, again, there's a thin piece of bone that separates the sinuses from the brain up here. And literally the bone that separates the sinuses from the eyeball is called the lamina papyracea, or paper thin bone. And if all else fails and medications aren't helping, we've tried multiple medications, antibiotic courses, steroids, and symptoms persist. Functional endoscopic sinus surgery is a procedure that you can use to open up the sinuses. You take those small openings into the sinuses, you surgically enlarge them, make them bigger so you can actually see into the sinuses. And if there's anything to clean out in the sinus, pus, polyps, whatever, you're using instruments to pull all that out. You're using shavers to remove polyps. And I should say, polyps we discussed, we'll talk about here in a second. Polyps can come back, but at least surgically we can remove them as much as possible and to help reduce the chances of that happening. But the goal is to improve your sinuses, to help them breathe better, to drain better. And a lot of patients need to continue to use those topical nasal sprays, those sinus rinses. Those medications can get in even better after sinus surgery. You're trying to prevent recurrent infections while at the same time preserving all of the normals. You're trying to preserve the normal structures in the nose so it still can operate as well as it should before surgery. This is a slide discussing balloon sinus dilation, whereas this sinus surgery was discussing surgical instruments to surgically enlarge using instruments and tools to enlarge those openings. In mild cases, you can actually balloon the openings. This is less invasive and the recovery is a little bit easier. This is a thread, or this is a picture showing a device putting a balloon into the sinus opening. You blow it up for several minutes, about a minute or so, and you're trying to help those sinuses stay dilated, and you can actually rinse out the sinuses through that same instrument. Again, that's for more mild sinus disease. Allergic fungal, this is its own beast. This is patients, it can be seen in patients that have allergies. Your immune system overreacts to fungus that gets in the nose. This is more common in the South, not so much where we live. And it creates a chronic sinus inflammation, nasal polyps, and thick mucus. We can identify it by these calcifications that develop in the sinus. It's this thick allergic mucin. It's often one-sided. And in patients, it's more symptomatic than your typical polyp patient. Rarely, not everything in the nose is just inflammation and polyps. Cancer in the nose is a possibility, especially for patients that smoke, have exposure to wood dust, for example, carpenters, furniture makers, leather dust, or even formaldehyde. It's one-sided nasal obstruction, and it's just not responding to medications at all. This slide is really just to highlight if there are any issues with medication, sinus inflammation that's not getting better. and you tried a number of things, don't just ignore it. You should come in and see us just so we can take a look. Patients, especially if you have facial pain or numbness, tooth loosening, or any swelling around the eye, those are all red flag symptoms. And they can often, and especially in the early stages, mimic benign conditions. So delayed diagnosis is not uncommon. So that's why you need a high index of suspicion to diagnose it. We can see it. We can look up with our cameras. We can biopsy it. So in summary, there's different treatment options for different forms of rhinitis, and it's tailored to each patient. And then there are multiple causes of nasal obstruction. They may not respond to medical device, or I'm sorry, just may not respond to medical therapy. Respond to medical therapy. Deviated septums, enlarged turbinates, chronic sinusitis, and nasal polyps, for example. So it's 52 minutes. Hopefully that was helpful. Any questions? Thank you, everybody.
Great. That was wonderful. So much good information. Just as a reminder, if you join late, you do have an opportunity to ask questions. There's a Q&A box at the bottom of your Zoom screen, or you can ask it in the chat. I've seen a couple come in, so feel free to ask away. One question I think was just confusion on whether subcutaneous drops were FDA approved or not.
Sublingual. Sublingual, to the best of my knowledge, they've been approved. And I'm not. We don't give them in my office, but it's through an allergist office. But it's a very common treatment, but it's indicated for patients with more mild cases of allergies. So allergy shots have been given for a while, but that's more indicated for severe allergies. Sublingual drops can be given in more mild cases, but I don't give them, so but I believe they're FDA approved to the best of my knowledge. I have a lot of patients that are on them from other allergists.
Great. The next question is, can postnasal drip cause vomiting?
In some cases, it can. Postnasal drip often triggers coughing, and coughing, especially if you're coughing a lot, can trigger vomiting. So it's not a hallmark of vomiting, but I've had patients that have said that. They're like, it's so much stuff and it's just draining down, because when it drains down to your throat, some of it sometimes goes airway, but it can actually just drain right into the food pipe. And if you have a sensitive gag reflex, yes, it can trigger vomiting. Not commonly, but yes, it can.
Can you highlight the new procedure for cryotherapy for chronic runny nose, non-allergenic?
Yes. So in those patients, again, for non-allergic rhinitis, where patients' nose runs frequently, regardless of, and this is actually, I highlight non-allergic patients, but you can still use it for allergic patients too. You're using a device that it looks like a small little tiny like plastic balloon, and we are applying to specific spots in the nose to target the posterior nasal nerve. By freezing that spot, it's kind of turning off that nerve, and it's about 20 minutes or so. We apply it to 2 to 4 sites in the nose. Right now we're doing the OR, but we're trying to work more to doing these in the office, because there's just in the OR someone's asleep, it's a little easier, versus in the office it can be a little more challenging, especially if patients have anxiety with nasal procedures. But you're targeting these nerves to turn off the nerve, and especially if a patient has a good response to ipratropium, that's what I like to see. I like to see someone has a good response to that medication. If they do, then this medication can be a more effective long-term solution. Typically, in about 2 to 6 weeks, you start to see an effect, and that effect can last for, now most studies will say up to a year, but we have had a number of patients that have lasted even longer than a year. So I don't know if that answers your questions altogether, but it's an effective form. If your nose runs all the time and ipratropium is effective, but you don't want to take ipratropium every day, then this can help.
Question. Many people want antibiotics for their sinusitis after several days based on having a sinus infection before, and it worked. When and how long should people wait to take antibiotics?
You know, most colds, when they start, like let's say you get a common cold, it's day 1 or day 2. Everything in the nasal passages and the sinuses are inflamed, you're going to have a viral sinusitis. When people talk about sinusitis, they're usually discussing or thinking about a bacterial sinusitis. That comes after and not everybody, but if you're having 7 to 10 days of symptoms, that's when that sinus that has been blocked off for those 7 to 10 days Now you have like it's a blocked off sinus that's just been sitting there like a closed room and it starts percolating and mucus is stagnating. That's a perfect medium for bacteria to set in. I say that because you can have discolored mucus early on, but that's not a predictor for what we call, for bacterial sinusitis. It's more how long have your symptoms been progressing. So I don't really, I mean, yeah, I really would not, in most cases, I would not prescribe antibiotics sooner than 7 days. I understand patients want to, they start to see the discolored mucus in the nose, and I get it. But if you can get by with just using saline rinses and blowing your nose out, that's what I recommend. The but it's usually a sinus infection, a bacterial sinus infection. It has to be at least 7 to 10 days, at least by the book, before prescribing antibiotics. And that's only after looking in there and seeing what we see. If it's been 10 days and I see green yellow stuff draining from the typical spots, then yeah, I will prescribe antibiotics often in those cases.
Great. I think this is the last question. So if you do have one that you want to ask, make sure to get it in. Um, this one says, or speaking of allergy shots, I received them when I was younger and they really helped. Just wondering if you will do an assessment up here or what the process is.
So allergies right now, there's no skin allergy testing in Tahoe. There's blood work you can order, but skin allergy testing is a little more comprehensive than blood work, which we do fairly frequently here. For allergy testing, it's a whole, you have to have a whole setup for it. And unfortunately, Tahoe right now, we don't have one. So we can certainly assess for symptoms and get address and look at blood work allergy panels. But as far as Barton bringing in, an allergist specifically for doing skin testing, I don't know if that's in the works. But we can also refer for skin testing. We don't refer all of our allergy patients. Not everyone needs to be referred for our allergy testing. It's only if patients have severe symptoms that are not improving with medical management and they're even considering allergy shots, or they just want they want a comprehensive understanding of their allergies, a little more comprehensive than blood work can offer. That's when we'll refer to allergy medicine to have allergy testing.
Great. I don't see any other questions, but I just will remind you that we did record this tonight and you can access it on our YouTube page. It's just youtube.com/Barton Health, or our Facebook page. And then we also have a post webinar survey that we'd love to hear from you on. How did we do tonight? What topics would you like to hear from us in the future? It really helps us determine good speakers like the one we had tonight. So, anyway, I appreciate everyone being here on this gorgeous sunny night. And I think with that, we'll go ahead and conclude. Thank you so much, Dr. Mantegi, for being here.
Thank you, everyone. Good night, and stop on by if you have any other questions.
Thank you.
All right, bye.